to the muscle, and the muscle membrane looks kind of like corrugated cardboard normally when you look at it. And in patients with myasthenia, that corrugation kind of breaks down, and so the surface area that's available for the chemical acetylcholine to cross over and stimulate the muscle becomes less in size, and so there's not as much availability to stimulate the muscle consistently in an ongoing fashion. And most of the medicines are aimed at either increasing the amount of the acetylcholine that's available to stimulate the muscle, or in terms of trying to suppress the immune mechanisms that damage the membrane on the muscle. And so we really try and focus on those principally, in terms of working on those sorts of things. There's a number of antibody tests, and it was interesting reading a little bit again today, as I'm prone to do it before I talk to people, that there's even a few more antibody tests now available than there were before. I remember talking to one of the senior guys in Ann Arbor about 9 or 10 years ago, and he said, boy, he didn't believe it was myasthenia unless he had a positive antibody test, and the science really doesn't support that. I'd sent him somebody over, he actually called me and said, I can't believe it, you have somebody who's got a negative antibody test, but they did, and there's a backup test called an anti-musk test, the acetylcholine receptor antibody test that we usually run. If you're negative for one, there's about a 50-50 chance you'd be positive for the other one, and then there's a number of more obscure tests. And these are all tests looking at proteins that are embedded in the membrane for the most part, and tell us more about the stability of the membrane in terms of its response to immune insult. It's probably one of the best characterized diseases in terms of actually knowing the physiology and the anatomy and the pathology of all of the immune diseases, because it's been studied for a very, very long time, and it's certainly easier to look at muscle than it is to look at brain or spinal cord tissue or eyes or lungs even, in terms of looking at these sorts of things, because we don't usually do muscle biopsies on MG patients. We're much better at diagnosing things now than way back when, but there was a time when those things were done, and the notion of being able to look at those things and understand what the chemistry and the muscle makeup was, particularly as it was close to the nerve, was available too. The most common drug used to treat is Mestinon, but both Mestinon and neostigmine, pyridostigmine and neostigmine, those are the generic names. I'm of the generation where we use trade names, so forgive me, I'll use those, even though it biases me, I suppose, a little bit. But Mestinon's been on the market throughout my whole career, and well before, I think, anyway. And edrophonium tensilon is another one of the drugs in that category as well. Tensilon is the shortest acting of those, and we'll talk a little about the tensilon test in a minute. Mestinon is the longest acting of that group, and neostigmine is the intermediate acting product in that group. Neostigmine is a little bit unstable and tends to be, you need to give that more in injections. You can give it in pill form somewhat too. All of them can promote gastrointestinal symptoms, nausea, diarrhea, vomiting, and the like. All of them can cause heart rate slowing. So we always have to watch for those types of issues in patients when we work with them. And too much can actually make you weak. It's not just a straight linear curve as we tend to think. A lot of the time it actually is more of a bell curve, and you get up to a certain plateau with the drug, and then you can actually start getting worse from having too much of it in your system. And so we often watch for problems with excessive salivation or GI symptoms as a means of trying to judge some of those things. There are some medicines, and it was kind of interesting. Probably the most common complaint I get is that people have GI symptoms that upset them in terms of taking the drug as regularly as they would. It was interesting reading through the Foundation's webpage on the physician section that they really do advocate a couple of drugs in there that I've used a little bit, but I haven't really pushed with too much, because there's a fairly low level fairly low threshold for switching people over to the immune suppressing drugs if you're not doing well on the Mestinon alone. And I tend to really work with the Mestinon as much as we can, because as you'll hear when we talk about the immune drugs and the other treatments, they tend to be a little more prone to troubling side effects and issues with them by and large anyway too. So anyway, that's kind of the first line drugs. Actually, the very first line of treatment is always to look for a thymus gland, though, because if we do see a thymus gland, we're going to take it out almost all the time. The incidence of thymoma is higher than what I've seen in my myasthenic population. We always look, but knock on wood, I've only had one. Well, I have two patients who've had thymomas. One fellow was terminal when he was transferred to this hospital from Florida after suffering a severe respiratory arrest and brain injury and remained on the ventilator for months until he died. Family had a lot of difficulty letting go in that case. So he and I actually never spoke. He was literally transferred to the ICU, to my service back in the days before hospitalist by his family doctor from Florida, unbeknownst to me. And he kind of dropped me in the middle of a mess on that one. The other patient I have that has it actually had her thymoma identified before her myasthenia showed up, which was kind of a little backwards in my experience. She actually had her thymus taken out because they saw it and they thought it was abnormal. And, so she had it pulled out, and then she developed the myasthenia. It was maybe even a year or two later, and even going back, we didn't really hear too many symptoms. She's actually an associate here at Lakeland and has a lot of contact with a lot of us in the medical world regularly anyway, which is good and bad. It kind of gives you a little more feeling for her history, but tends to sometimes make people a little more complacent when they're around doctors all the time in terms of keeping up with the care they need anyway too. So anyway, we take thymuses out. They say we'll find them in 10 to 15% of patients. The thymus is a residual gland from when we're children, and the white blood cells are grouped into two groups, B cells and T cells, in terms of broad categories, and the term T cell comes from thymus. And so when we take the thymus out, it's not the only place that T cells are produced, but it certainly can produce a great number of them, and that's one of the principal problems in terms of the T cells attacking the membrane that we were talking about a moment ago. So a lot of the medications are geared towards blocking that attack. So the surgery blocks it. Surgery is usually not curative, although in some cases it can be, but it usually improves people's symptoms substantially if they have it. Men have a little higher incidence of having thymoma than women do. For some reason, the disease has a weird, what's called bimodal distribution. We see it in women in their 30s and 40s, and we see it in men in their 60s and 70s. And I'm not sure we completely understand why it's not, a little more predictable in terms of circumstance. I think that's still being looked at this point anyway. So anyway, to go back to the medicines, and the group of medicines I was mentioning at first were called the anticholinesterase medicines. And those medicines, acetylcholine is made in the nerve ending, and then it's released. And there's about maybe 100 quanta or packages, if you will, of acetylcholine available for the initial transmission of a nerve membrane. And then if that nerve keeps firing, what happens is that acetylcholine crosses the membrane cleft and then attaches to the muscle membrane, and then causes the muscle to depolarize, the electrical thing that makes the muscle contract. And then those elements will be reabsorbed into the nerve ending and then reconstructed into acetylcholine again and held in packets that are ready to be released again. So for any single stimulus, we see about 100 of those quanta released. And then if it's a repetitive thing, there's probably around 1,000, and then at the most basic level where it's putting those things together, there's about 100,000 of those quanta available to be released. So we can start mobilizing a fair amount of acetylcholine if we're out for a walk around the block, say, or if we're gardening, or if we're washing our hair, or if we're just reading.